Good morning, everyone, and a big thank you to whoever's made it for today's first day, first session of this test match series. Can we have the presentation, please? So many thanks to speakers for making it here on time at 8 in the morning, and a big thank you to the delegates who managed to reach here and take part in this unique instruction course, which we've called as the Kochi Glaucoma Debate, or the Ultimate Face-Off. I'm Dr. MOVDAWALLA, I'm the Chief Instructor, and I'll be giving you a brief introduction and a scope or the need for this particular debate. No financial interest in the following presentation. So we all know glaucoma is an ambiguous disease. It's a gray disease with no absolute black or white. There are vast modes of presentation in glaucoma. You may have somebody walking into your OPD absolutely asymptomatic with no complaints whatsoever and may have advanced disc damage in glaucoma. And on the other end of the spectrum, you have somebody walking in with a swollen red, painful eye, vomiting all over the place with pressures of 40 and 50, and yet having an absolutely healthy disc. Vast number of diagnostics tools, measuring RNFL, disc parameters, perimetry, and of course treatment options. Treatment options, again, from one end of the spectrum where it could just be a simple wait and watch to advanced glaucoma surgical options which are there. So the treatment outcomes vary from patient to patient, and there is no one-size-fits-all strategy. It has to be highly individualized, and the treatment depends, again, a lot on the surgeon or the consultant's own practice pattern and experience. Hence, the need for a debate-minded approach for certain glaucoma, scenarios in glaucoma, where both sides of the coin are assessed and discussed. So the first debate of the day is the age-old conundrum of structure versus function. A structural test looking for glaucoma-related optic nerve damage, especially thinning of the RNFL, form a very, very important part of glaucoma diagnosis and management, and used in tricky conditions, especially like pre-perimetric glaucomas or disc suspects. We have vast variety of, again, structural tests, ranging again from basic disc photographs, stereoscopic disc photographs, disc diagrams, RNFL measurements. Earlier we had the HRT, the GDX, and newly the OCT angiography. But what is the utility, we shall discuss. Again, functional tests, especially perimetry, form the backbone of glaucoma armamentarium, from diagnosis to progression as the must for every patient. Now, are structure and function supplementary or complementary to each other? We will try to see that in the first debate of the day. Our second debate is the role of anti-glaucoma medications versus minimally invasive glaucoma surgery in glaucoma-controlled patients undergoing cataract surgery. We all have a large number of patients who are on medications undergoing cataract surgery, and the standard of care for many of them has been just to do the cataract surgery and continue the medications for them. Now, should we maintain status quo or try something different? We all know MIGS is the new kid on the block. We have bent ab interno goniotomy, KDB goniotomy, or the eye stent. So in this second debate, we look at this, whether anti-glaucoma medications versus MIGS in these situations, looking at the pros and cons of both approaches, most important, looking at overall impact on cost and quality of life. And our third debate is role of trab versus tube in first-line surgery, as a first-line surgery in primary glaucomas. Trabeculectomy has always been the gold standard for surgical management of primary glaucoma. It's cost-effective, relatively easy leaning curve. However, early and late complications make it unpredictable in the best of hands. Tubes, as we all know, either valved or non-valved, are the mainstay in secondary glaucomas, but can be used in primary glaucomas as well, which the primary TVT study has shown. So in view of the fact of documented fewer vision-threatening complications, is it prudent to shift our approach or stick to what works best in our hands? So this will be the point of contention in a third debate of the day. So each speaker will speak for 7 minutes. We keep the discussion as clinical and relevant as possible. We'll take questions at the end. And let's hope for a fruitful and no-holds-barred debate session for the day.